third topic is vascular resection and reconstruction, particularly portal vein invasion. Probably you face frequent portal vein invasion in perihilar frontal fractures. You can see left, right, anterior, and post. This is a very clear image of the three major veins. But this, you can see the right invasion. But this is a unilateral. You can divide. This is the right-sided hepatectomy case, so we can divide the right root of the right portal vein like this. So this stage unilateral portal vein invasion, and this will bilateral portal vein invasion. You can see the resection line like this. Just shows indicates right hepatic trisectionectomy. This is a bilateral portal vein invasion needs a portal vein resection and reconstruction in this case. Over 40 years ago, around the 1980s, portal vein invasion, bilateral portal vein invasion is a major barrier for curative resection in biliary surgery. But now, as you know, not anymore. We can apply a technique of portal vein resection and reconstruction in such advanced case. This is a total cohort of the Nagoya University Hospital. Our resection rate is 67% here, and most of the patients received the major hepatectomy, about 97%, and divided into the hepatectomy type is shown here. Right hand hepatectomy, left hand hepatectomy, left trisection, as shown before aforementioned. And each hepatectomy has a specific feature of the combined procedure. For example, this is green color shows a pancreatoduodenectomy. So right hepatectomy and pancreatoduodenectomy is very common. The other type of hepatectomy, HPD, is very exceptional or relatively rare. And portal vein resection focus of this lecture. You can see the higher in trisectionectomy, right and left. And left hepatectomy a little bit lower. And the hepatic arterial resection is largely present in the left-sided hepatectomy practice, and right-sided hepatectomy, hepatic arterial resection and reconstruction is very rare. So they summarize here, in the overall portal vein resection needs about 30% in higher cholangiocarcinoma. So it's a very common procedure and needs for you practice needs this technique. The incidence is shown in the border of the incidence and shown here. Left trisectionectomy, right trisectionectomy, and this is the hepatectomy side, about 20% or over. This is about 40%. So, but we had some problem about portal vein resection. The first is the institutional or personal experience of portal vein resection is still very limited. This chart shows a summary of the literature and the number of portal vein resection. For example, Ebata in Nagoya reported 47%, and this is about 40 or so is very common. And Mizuno, this is from the Nagoya University report, and reached 147 patients of the portal vein resection. And case load, that means the number of resection per year in the hospital is very low generally. In previously, now hospital was 2.5, only 2.5, and now we reached 8.7. In a year, we performed 8 patient portal vein resection in 8 patients. So, and another is a non-standard, so associated with the limited experience, we have no standardized technique for management, and also the controversial indication. For example, indication is some surgeon perform the portal vein resection routinely without invasion in patient without evident invasion, they perform the portal vein resection. Now, this routine policy sounds very nice for surgeon and very attractive to be surgeon in the world. But so the portal vein resection has two issues which is still under debate. It's first is the timing before hepatectomy or after hepatectomy. And the second is the indication, routine or on demand, if needed portal vein resection case. I summarize first I summarize the timing of the portal vein resection. This is the case here, the portal vein resection after hepatectomy. And finally, we devise the portal vein resection and specimen removed, and now we perform the portal vein reconstruction case. This is another phase. During the preparation of the hilar dissection, in this step, we perform the portal vein resection and reconstruction. This technique is first reported in Sakaguchi in 1986, and Neuhaus, Professor Neuhaus, a famous German doctor, in 1992. But the applicability, it means this can be done in any type, any hepatectomy type. But this first portal vein resection can be performed only in right side of hepatectomy. And the field of surgical view is very good because of nothing. But this is often narrow. This is a very, I select a photo of the very good view. But sometimes this is a very narrow surgical field, and technique cannot be performed easily. And inflow control this is complete because of the resection. First we perform the resection. So the small caudate low branch flow is completely controlled in this procedure. But this is incomplete. So risk of congestion is possible in after hepatectomy policy, but this is risk of congestion is none in before hepatectomy portal vein resection policy. I would like you to take care about this risk of congestion bleeding from the resected side. So this is a typical congestion bleeding seen from the resected liver. This is a plan. Now we plan a left trisectionectomy or portal vein resection, and after portal vein embolization. So I mean the left liver is portal inflow is completed because of portal vein embolization, but we perform okay, this is a portal vein embolization, and in this phase we devise hepatic outflow. But unfortunately, we remove this. This is a congestion bleeding from this left side. This is very simple because of this congestion bleeding is a surgery-induced physiological failure, only this. So trigger one, division of the total outflow vein. So the final hepatic vein should be preserved because of Puanai said in his discussion, he divides the hepatic vein in the last phase. So this is an important point. And second, declamping the pringle maneuver. Because the time is limited, our hospital clamp time is 20 minutes. So in the procedure, sometimes we have to declamp the pringle maneuver. So this is a very two trigger and cause one portal perfusion remnant. Now, why this physiological phases occurred because of the portal perfusion remnant, probably the minute portal flow of the caudate branch, and sometimes the portal vein embolization failure, the canalization of the some, for example, right anterior portal vein. And the second is the arterial perfusion remnant. It's also present This is an anonymous branch, but A1, we call A1 caudate branch or duct branch. So this is a right trisectionectomy case. The clamp this and divides this. And this we divide the middle hepatic vein after we just and the clamp here. This is a ducted. Hemostasis of the duct is performed. During this step, we face the encounter the bleeding like this. Controllable bleeding from the rejected side. So this is the first step compared to the difference. So emergent portal vein resections performed during the 5-minute background purge or rest time. Swelling the liver, you can see the swelling, very swelling the liver in the liver. So this is so we have to take care about the step of the vascular division. This is a time before and after problem. The next is the indication problem, routine or on demand. As previous said, Professor Neuhaus, a very famous German doctor, proposed a routine portal vein resection called unbroken non-touch approach. This sounds very nice for HPV surgeon. They initially dissect the vascular in the hepatoduodenal ligament like this and divide the right hepatic artery here and first. And reconstruction, portal vein resection and reconstruction performed like this. But the recent March center study failed to confirm the sorry, this is his data about the Berlin style. Two different published data is shown here, but we focus on the 12% mortality here, routine strategy, and this is a conventional strategy. Routine resection cases has a better survival compared to the strict portal vein resection approach. And this difference keep 10 years after, but the mortality is also present about 12%. This is for the recent March Center study in the versus German versus Netherlands one published in 2022 failed to confirm the benefit of routine portal vein resection policy. Surprisingly, high mortality is also observed. Right, very high. And the survival, long-term survival is comparable between the two groups. And this is another study, a recent March Center study. This is published in 2022, failed to confirm the benefit of the routine PVL resection. This is a routine portal vein resection, and this is also the usual strategy here. The mortality is very low mainly because of the surgical mortality reduce the survival people. So survival of a routine group as so indication portal vein resection is should be performed on demand or selectively. Right, which is you can see the portal vein invasion during the surgery, then divide and reconstruction like this. So this is a summary of portal vein resection and reconstruction at Nagoya University Hospital. indication on demand. Timing, we do not particular about the timing, but we should prefer to after total pain resection reconstruction. And resection type where the segmental is larger now, end-to-end anastomosis with a intraluminal and open suture technique. And if we needed the graft harvest, we write, our preference is right external iliac. This is a technical, basic technical portal vein anastomosis. This is probably the very common. It's not probably you perform in the same amount. This is after hepatectomy. We perform the portal anastomosis like this. 2 stitches pressed like this and intraluminal suture and anterior over. Play a little bit there. Well, this is a finish of the portal vein anastomosis. This is a very common approach. So, but the important point is to avoid deformity and thrombus associated with portal vein resection. So ideally, place vascular clamp appropriately means 1 centimeter suture margin stay here, right, like this. And stitch finally uniformly and carefully, loosely with a bit growth factor and provided AP3 to keep the level when needed. So this is the re-anastomosis case in no, this is a basic another basic technique in our Nagoya University Hospital. Rotating anastomosis. Place the vascular clamp and cut. And anastomosis. This is the point. I draw a line in the ventral side, but this is a little bit, this liver side is rotated, a little bit rotated to 10 degrees clockwise. This is a rotating anastomosis in right-sided trisection, right-sided hepatectomy. This again we show the vascular clamp placement. When you place a straightly or straightforwardly, the line is situated on just on the center here, but we little bit rotated like this. So this hand and rotation and place a rotation in the spot. So the vascular clamp placement is very important. For your easy understanding, I draw a line like this. Okay, so I want to say to the youngsters that PV appearance everything in this surgery. So we have to check the surgical sign of failure, stenosis, thrombus, tension, and torsion, twist or kink, and the dimple. So if you see these findings in the portal vein, we have to re-anastomosis. Do not hesitate to redo anastomosis when it seems not so nice. This is a typical case of 2 times re-anastomosis due to twist and pipe blockage. This is the first anastomosis finished in right-sided hepatectomy. This is typical twist image. This is good, but you can see the twist fine. So second anastomosis is run. And remove the anastomosis side and re-anastomosis here. But this is not good because of the US, local US shows a hypoperfusion here. So 3 times anastomosis is shown. In this time, we place the vascular band in a different way, straight ventral to the dorsal side. So sometimes we vascular pump angle and repeated distance is very important. Remove the anastomosis and same technique, intraluminal technique, suture technique, and overhand order. After 3 times anastomosis, I satisfied with the outlook of the portal vein. So I show another case. This is something palpable in the portal vein by palpations. And also this is a little bit with acceptable rotation shown here. Okay. But there's something palpable, so it's soft like gummy. So we re-anastomose here. You can see the small thrombus here. Also, this is a very small thrombus. This also thrombus. So you Doppler don't demonstrate this portal thrombus. Of course, US Doppler in the liver is a good perfusion. So palpation is very important after portal anastomosis. Perform the backflow breathing to flush the potential remaining of the portal thrombus and the anastomosis practice. So this is our result of the portal vein and the reconstruction. In 1991, the Grandmaster Nimura first reported 98 patients who underwent portal vein resection. He performed several types of portal vein resection. So our method is the same of this period over 30 years ago. But caution should be paid the mortality and survival rate. Only 6% at 5 years at this period, but better than unresected cases. This is a reason why they aggressively perform the portal vein resection case. Because at that age, unresected patient has only 4 months median survival time of only 4 months. This is a point of that age. So the portal vein resection and reconstruction is justified at that age, but now probably different. This is a 10 years later. I summarize portal vein resection cases. This is a non-portal vein resection case, and just two graphs as a portal vein case. But survival is only 20%. But now our result is here. Portal vein resection case has a 35% survival rate at 5 years, and when without it's 59%. So portal vein resection and reconstruction is technically demanding, but result, short-term and long-term result is improving step-by-step manner. And this is another conclusion, the portal vein resection and reconstruction in perihilar cholangiocarcinoma. So portal vein resection should be performed on demand. Namely, when you see or feel a portal invasion during the surgery. And next is the appearance, everything after portal vein anastomosis. So gross inspection is very important. and do not hesitate to redo anastomosis when you see the not so good finding at the portal anastomosis side. And always prepare for possible portal vein thrombus. This is my message about the portal vein resection and reconstructions. Thank you for your attention.